intake, but patient was able to take liquid foods without any vomiting. There is no history of abdominal distension, ball rolling movement, or awareness of lump in the abdomen. Patient has modified his diet to only liquids in view of vomiting, because of which his vomiting subsided, but still his nausea persisted. Next slide. 4 days back, patient also noticed yellowish discoloration of urine followed by ice, which was progressive in nature. It was not associated with any pruritus, but pale stools were present. Also, it was associated with high-grade fever, associated with chills, no rigors. It was which was relieved by oral paracetamol, and at times he was requiring IV paracetamol at local hospital. There is no history of alcohol intake, prodromal symptoms, or any CAM intake. No history of blood transfusion, tattooing, or high-risk behavior. Patient does not have any anorexia, but there was a weight loss of about 3 kgs over the past 1.5 months. Next slide. These symptoms were over a background of about 1 month prior to onset of the presenting complaints. Patient had a severe upper abdominal pain and associated with multiple episodes of vomiting, for which he was hospitalized. He was admitted to the ICU. He was given oxygen support, kept nil per oral, treated with IV fluids and medications. Blood investigations and an abdominal scan was done, and he was told that he was having a pancreas problem and gallbladder stones. Subsequently, he was started on liquid diet, shifted to ward after 4 days, and discharged after 1 week with an advice to undergo lap cholecystectomy. About 10 days later of onset of these symptoms, he underwent lap cholecystectomy, which was on 4th of July, which is 20 days prior to the onset of presenting complaints. Immediate post-operative period was uneventful. He was discharged after 2 days in the hospital. He was apparently normal till the onset of presenting symptoms. Patient, for the past 10 days after the onset of these symptoms, patient was receiving symptomatic IV medications for his abdominal pain and vomiting at a nearby local hospital. Upon onset of his fever and jaundice, he has consulted his operated surgeon, where he was initially investigated with blood investigations, and repeat abdominal imaging has been done. He was started on IV antibiotics and was referred to our institute for further evaluation and management.
Can you just stop here?
Yes,
ma'am. When do you think this patient has actually started falling sick? So if this patient comes to you in the OP and you ask questions, like he says, I've been unwell for 10 days.
Yes, ma'am.
So would you really just start off the history as 10 days back? What I would do is I would just go back, because somewhere down the line you mentioned weight loss of
3 kgs.
3 kgs over 6 weeks period.
Yes, ma'am.
So then I thought probably your history should have been dated to
6 weeks.
6 weeks back, and then the history comes back, there is a weight loss, and then the patient has this particular symptom. Okay. But then there's actually a problem 6 weeks back.
Yes, ma'am.
There's a problem 6 weeks back, and there's hardly been any symptom-free period.
Okay.
There's hardly been any symptom-free period. So in a given patient, in a patient presenting with this, one thing that you should always do, because what we usually do, at least what I would do in the outpatient, is I will keep on going as far back as is possible and say, tell me when you were well, when you were keeping well. So then we will say that actually I was well in the month of May.
Ma'am, this patient actually, like initial his ICU admission followed by lab chole, there was some weight loss.
What I'm saying is,
yes, ma'am.
Do you think from whatever you've described so far, is there a link between what was there in May and the presenting complaints now? That's all that we need to know. If there is a link, then it's a continuum process. If there is no link, then there are two different problems in this patient. What do you think? Because I do not know what the case is. So as you're taking the history,
ma'am, that's this patient initially had his admission followed by surgery. After that, during that period, he has lost 3 kgs weight. Following surgery, he was fine for 20 days, and he actually has put on weight 1 kg after that. Then again, after the initiation of these symptoms, presenting symptoms, he has lost 2 kgs weight, ma'am.
This particular weight loss is more due to his jaundice that he's had. No? Then,
Yes,
as
ma'am.
usual, all of you please switch off your videos, okay, except those who are presenting. It's distracting. I'm not able to take a class. I'll just shut off the computer then. Those who are not presenting, please switch off the video. So in this particular patient, what you would actually, what I would actually think is that I would consider what really happened in the month of, say, May. What was the presentation in the month of May?
He had severe abdominal pain, ma'am, gastric pain associated with multiple episodes of vomiting.
So he had acute. So this vomiting is usually a reflex phenomenon. Okay.
Yes, ma'am.
Any pain, a ureteric colic also presents with vomiting. So usually what happens whenever there's a pain, a man or any individual, they either try to pass motion to relieve the pain, or they'll vomit to relieve the pain. It is a reflex phenomenon. You have to decide whether it is just part and parcel of that particular symptom, or actually there is a particular pathology that is causing him to vomit.
Yes, ma'am.
There are two things. No, one is he may be actually having a gastric outlet obstruction and he's vomiting. I'm talking the first symptom, not the second.
Yes,
So that is one possibility. So either he actually has a problem, two problems. He has a vomiting and he has abdominal pain, and then you think it was gallstone or whatever it is. So most of the times when a person has an acute pain, abdominal pain, and we're not talking about small intestinal pain, a ureteric colic, or a patient with a gallstone or a gallbladder colic or a cholelithiasis with a colicky abdominal pain, invariably the pain is so acute that they'll keep on retching, hoping against hope that they'll get relief of pain. So do not attach so much importance to the pain at that juncture. Okay, because the first instance, the pain that was present in this patient is part and parcel, the vomiting was part and parcel of the abdominal pain.
Yes.
So can you just describe the pain once again, the first episode, whether you think it was a gallstone pain, or do you think it was a pain related to the other gallstone pain, or the vomiting was related to the gallstone pain? It was independent. Describe the first pain. Yeah, the June 25th pain.
Ma'am, he had a epigastric pain. At the time, it was radiating to the back, upper back, and it was associated with multiple episodes of vomiting. Vomiting was
it's just the vomiting. So if I were there, I would say that patient is absolutely doing well. That's the classical presentation of a gallstone pain.
Yes,
so they're asymptomatic until the previous episode of pain. So when the pain starts, they get an acute pain.
Yes,
so it is a sudden onset. So you should say patient was doing really well until June of 25th. This is how you start the history.
Okay.
And then say on that particular day, one particular day, that is on June 25th, while he was working, he had a sudden onset of pain, which was localized to the right hypochondrium, and which they mentioned it was sudden onset. It increased in intensity, described the graph, and continued to remain for 4 to 6 hours. And until he went to the hospital for relief of the pain, the pain persisted. This particular pain was localized to the right hypochondrium, as I already mentioned, with radiation to the right back, with no specific radiation to the right shoulder.
Okay.
So you're describing that particular pain. During this acute pain, he also had vomiting, trying his best effort to get some relief of the pain. Now, describe the pain in such a way that's not pancreatitis, no? Then you just see that so what happened? And now, for this particular pain, he cannot be admitted to the ICU. For this particular pain, he cannot be admitted for the ICU.
Okay.
No, this particular pain, he will not get admitted to the ICU, no? Just the pain.
Understood.
So when such a pain results in an ICU, one is unnecessary, you get admitted in ICU, that's a different issue altogether.
Yes, ma'am.
So if a patient has one episode of pain, unless he goes in for hypertension, unless he goes in for some acute problem, which will take at least 1 or 2 days for the pancreatitis to settle. An acute pain will not result in an ICU admission.
Okay.
No, one sudden onset of pain. So just be very careful, oxygen keeping nil oral. So how long did that first pain last? How long? You've got 1 month prior to this onset. There's one severe abdominal pain. Is it one episode? Or it continued like an acute pancreatitis? So can you just tell me what happened to that pain?
Ma'am, it was a continuous pain, ma'am. It started around. Yes,
Yeah.
ma'am. It started in the midday. He was working.
Yeah, yeah. So sudden onset, and then how long did it last?
It was continuous pain, ma'am, not relieving, and it lasted till the evening. So because the pain was continuous, he has gone to a hospital, like the
Now,
hospital.
under that circumstance, why should he get into the ICU? Unless he's got a perforation. So if we have had patients, my own cousin, he had an acute pain, he rolled onto the floor, and actually it was a DU perf. And the patient collapsed. That's a total different issue. So either you have to, so if a person has pain for 6 hours, why should he get into the ICU? What makes this patient be shifted to the ICU? How old is the patient?
66 years, ma'am.
66. So did he have, was it actually a myocardial infarction that was mimicking as an acute abdominal pain in the upper abdomen? It was a close mimicker. These are the things that should cross your mind. You understand? Patient has got pain in the right upper quadrant. That's what you feel. Epigastric pain, in fact. So ischemic heart disease pain can manifest in the epigastrium. So to my mind, it would be why did he reach the ICU? Why did he require oxygen support? If the pain was, because you said subsequently gallstone, so I'm trying to build up the history. Then gallstone pain, 6 hours pain should not make him land up in the ICU. So I would still consider whether he had an ischemic heart disease, a myocardial infarction, acute pain, which you did not know, then you have to bring in your sweating, palpitation, because you're bringing in the oxygen support, nil per oral. And then I think, is it an acute abdomen, like perforation, or is it actually a cardiac issue, or some other rupture or something that's actually causing this epigastric pain? Your mind should work in that type of a direction.
Okay.
You understand? And then, so then he gets into the admit, then he was started liquidine and shipped to the ward for 4 days. Now, to me, it would be that this particular patient, and don't mention all this, blood investigation, abdominal scan showed he was pancreatic problem and gallbladder. No, this is not the way to describe.
Okay.
Yeah, then there's nothing more to discuss in this case, no?
Yes.
To me, I would just say he had acute pain, rolling pain, he was very sick. He landed with ICU. I would mention that he had no palpitation, there was no breathlessness, there was no sweating. And for these particular symptoms, he was admitted to the ICU for observation because he's 66 years old.
Yes.
And whether he went in for hypertension and therefore he required ICU admission. So that's the way your mind should work. Do not get carried away by the pancreas and the gallbladder. I'm not interested at all in that.
Yes.
We're not interested in that. And 4 days later, he goes back and goes home and comes back. Makes no sense to me. Okay.
Yes, ma'am.
So in this acute pain, in the exam, they'll keep on hanging on to this acute abdominal pain that this patient had and reach the ICU and required oxygen support. All this will be hanging on to ischemic heart disease, non-cardiac chest pain. Is it an aortic dissection? What is it that really made this patient reach an ICU? How often have you seen a gallstone pain reach the ICU? You just give an analgesic or NSAID or something and the patient gets relief of pain, no?
Yes.
They usually never land up in an ICU. So after this, now tell what happened. So then, he had this problem. He was investigated and he was diagnosed, just leave it like that. He was diagnosed to have gallstone disease and was asked to undergo an elective cholecystectomy at a later date.
Yes, ma'am.
Right? That's what it was, no?
Yes, ma'am.
And so after how many days then? 5 plus 4, after 10 days.
Yes, ma'am.
So 10 days. So 10 days after discharge, patient had an elective cholecystectomy, right?
Yes, ma'am.
And which was, next is underwent cholecystectomy. Was it open or laparoscopic?
Yes, ma'am. Laparoscopic.
Laparoscopic. And then you have to say he was discharged the following day and the surgery was uneventful.
Yes, ma'am.
And I know that the surgery had nothing to do with the
Presenting complaints.
the subsequent presentation. So he was discharged after 2 days. Normally they would discharge after the next day. They don't even wait for 2 days. If a patient with lap poly has even a mild pain or fever or any symptom post-lap, then that means there is some complication. So it has to be uneventful. Patient was normal. There was no drain placed. It was an uneventful recovery. It was not a difficult surgery. And patient had an uneventful recovery and was discharged home. And he was doing well until now you come to the previous slide.
Yes.
Then come to your previous slide. This one. So he remained all right for how many days now?
20 days he was all right, ma'am, after the surgery.
So he was asymptomatic for 20
Asymptomatic.
days.
Yes, ma'am.
And he went back to his routine work.
Yes, ma'am.
He went back to routine work and went back to his routine activities.
Yes, ma'am. His routine activities he was doing, and
Okay.
oral
Okay.
intake was also now.
Okay. Now what happened after this?
Now he presented with
A
sudden,
similar pain.
yes, ma'am, sudden
A
onset of,
similar pain. So
yes,
now
ma'am.
there is one other condition now. So here's a patient who is an acute pain, who had required an ICU admission. To me, all the other things would also come into my mind. And then incidentally, there was also gallstone disease that was detected.
Yes, ma'am.
And the patient underwent elective cholecystectomy. This whole thing was uneventful. It was totally normal. And then 20 days later, when everything was settling down, this is how you describe.
Yes, ma'am.
Patient had once again a similar episode of pain. Now describe this pain. Now describe this pain.
Yes, ma'am. It was started
Similar.
about,
So it is similar. It is almost similar, no?
yes, ma'am.
Similar again in epigastrium. Again, it is localized. But this time there is pain, there is fever, and there's jaundice.
Yes, ma'am.
Diagnosis is so simple. The diagnosis is straightforward.
Yes.
Simple. But if you have not mentioned that history and you mention this history,
Yes, ma'am.
and then you go backward, you're going to lose the complete sequence of events. What is it? It is just a retained stone. It's just a stone in the CBD. Most probably that is causing polydopolithiasis, or cholangitis, and fever with chills. You will be able to explain if had you mentioned that first.
Yes, ma'am.
Because towards the end you mentioned he had that weight loss. No? So I was wondering what's his weight loss. So I would not attach much to the weight loss. He's had pain, so his eating habits would have become less over a period of time.
Yes,
And it's not a very big weight loss. 3 kilos weight loss for a patient who had acute abdomen, 66-year-old, getting into the ICU, moving out, and had a lap chole, uneventful, and then he comes back again. So I would put it like this: that patient was doing well until 25th of May, is it?
July, ma'am.
No. The previous one, 5th, whatever date it was, May.
Yes.
The
June,
previous
ma'am.
one.
25th June.
June. So I would just say that patient was doing really well until 5th, and he had a sudden onset of pain. It was acute in nature, unbearable. The patient was in acute, I think, with radiation to the back, and to the extent that he almost collapsed, and he was rushed to the hospital, for which he also required an ICU, just put ICU admission for observation. And during that particular workup, that's how, this is a short case actually. During the course of workup, he was told to have gallstone disease, and the recovery was uneventful. Patient was discharged within a week of admission, and patient went home and then underwent a elective cholecystectomy for the symptomatic gallstone disease, most probably. So it may not be symptomatic. The symptoms may be still cardiac or any other cause. But he's undergone a cholecystectomy, and patient was doing well. For the next 20 days, patient went back to his routine day-to-day activities. He was normal, he was eating well. Everything had just settled. Then he noticed one other acute onset of a second episode of an abdominal pain. This was again localized to the epigastric region. Almost the pain characteristics were similar to the first. So I'll describe the first one in detail. Similar to the first one, but this particular pain again was associated with vomiting. I'm not worried about the vomiting. There was so much of description of that vomiting and stale food. Now, can you explain this particular symptom that you have? You discussed partial undigested food, then something and non-bilious, non-project. Can you just bring in this particular vomiting this particular patient has at this juncture after 20 days of the elective surgery? What all could have happened? You have to explain, no?
Yes, ma'am.
Either you want to attach importance to the vomiting, or you just want to say that this was just other phenomenon, because to some extent you said partially digested, then he said to the extent now he's able to take only liquid food. So how many episodes of pain did he have after 25th July? One day he had, then?
He had multiple episodes he was describing.
How many days? How many days?
10 days, ma'am. Like from 25th till patient presented to us on 5th of August. So about 10 days history of total complaints, ma'am.
Yeah, so 10 days can a patient manage with an acute abdominal pain, repeated episodes of pain? Now describe one pain and tell what's the duration and how many he would have had per day or per week or for those 10 days. Supposing in 10 days he had 2 episodes, and he say, okay, I had one pain, I think I'll wait. But supposing he has pain day 1 on 25th, then again 28th he has a pain, 30th, no patient will stay at home with that severe pain.
Yes.
Now describe this particular phenomenon of pain after the 20 days of the surgery.
Yes. So,
Try to get us some information as to what is this pain.
ma'am, this patient had epigastric pain, which was continuous, dull, and it was severe in intensity.
So it cannot be dull and it cannot be severe. No, the adjectives are two different. It cannot be dull, it cannot be severe. Either it is severe and it's not dull. Dull is dull ache. Severe is severe pain. Dull is a dull ache. Severe is a severe pain. So is it a dull pain or is it a severe pain?
It was severe only, ma'am.
It was severe. So then don't tell about the dull, because I was confused. How can you have a severe pain and a dull pain? You cannot have a dull ache and a severe pain.
Yes, ma'am.
Because from your history, I would like to come to a conclusion as to what is the possibility.
Yes, ma'am.
So there is a severe pain.
Uh,
How long would this pain last?
Ma'am, the first episode, it lasted about 5 to 6 hours, ma'am.
Okay, then?
So because the pain was, occurred, like it was severe, he has again went back to the operating surgeon. So where he was given IV medication. After that only pain has subsided. So then following that, he was having the same pain, but it was milder in intensity. But whenever he is having food, especially, it aggravates after food intake and subsides over like next few hours. It again subsides.
So what is this pain now? What is this that you want to convey? You want to say there's a DU?
I was thinking more of pancreatic involvement, ma'am. Maybe local complication.
Just tell what are the things that keep coming into your mind? Because there is a pain which is related to food intake, which is acute in onset.
Yes, ma'am.
And then lasts for a few hours. First pain, he went to the doctor, he got relief, but subsequently there's a food-related pain. Can you describe this food-related pain?
Usually, such a kind of pain can be because of a like duodenal ulcer, or it can be pancreatic.
So if it's a duodenal ulcer, what will be the relationship of food and pain? It'll get relieved, no?
DU can be relieved, ma'am.
DU will get relieved.
Yes, ma'am.
Yeah. Whereas GU will not.
Will aggravate after food intake.
But it depends on the site.
Yes.
Because you know what's happened after some time, as you kept on reading, you said the vomiting occurred soon after taking food.
Yes, ma'am.
So when would such a situation occur? When will a person have vomiting soon after taking food? See, when you're describing certain things, I'm imagining what's happening to the patient. When will a patient have vomiting soon after taking food? He takes food and he vomits. So either there's some problem at the OG junction, number one. Yes, or it is a GU that is placed in the juxta OG junction, adjacent to the OG junction. Yes, because juxtapyloric or duodenal ulcer pain will all get relieved. But gastric ulcer, either in the stomach or adjacent to the OG junction, are the ones that initiates vomiting. That's a classical description. A GU or a growth or something that's there, that can induce vomiting. But they will not cause pain, not this severe pain. A GU will not cause this severe pain.
Yes.
So this is one possibility.
Yes, ma'am.
Now, if you take pancreatic pathology, then in the pancreatic pathology, will you get this type of a vomiting and symptoms related to this?
Fluid collections can cause like.
Then you would have had abdominal distension. You should at least have some fullness. You should have had some symptoms to suggest that there's a complication of the so-called choledocholithiasis with pancreatitis. It's possible. And now it's almost 4 weeks, no? 4 weeks. So is it forming a pseudocyst? And therefore, it's causing compression on the antrum and then causing gastric outlet-like obstruction. Then you describe the pain as a dull ache.
Yes.
Then don't bring in the severity. Acute pain, maybe there's a choledocholithiasis, impaction at the sphincter of OD, and then the patient has acute pancreatitis, and now it is complicated pancreatitis. But it is only 10 days. So in 10 days, you can only have fluid collection, no? You cannot get a pseudocyst.
Yes.
So in this context of pain 20 days after surgery and having an acute pain presenting with vomiting which is more like a gastric outlet obstruction. When can such a thing happen? When can it occur? That's so. If you have that in mind, it's easy to move forward with the history taking.
Usually after it takes a few weeks to have
Yeah,
the collection.
at least 3 to 4 weeks, no, for the
Yes,
fluid collection. So you have also examined the patient. I have not examined the case. You also examined the patient. So maybe you found a small, a vague mass, indefined mass, but then you mold your history into such a direction that you want to convey, and you can mention that you also noticed some fullness in the upper abdomen. Then it is easy for us to understand what's happening. If on examination nothing is there, and he's only got jaundice,
Yes.
then you cannot explain everything. You cannot explain the vomiting.
Yes, ma'am.
Okay. So just be careful. This is one possibility. Any other situation when you can get such a situation where the patient has had polycystectomy and the patient is vomiting 20 days after that, the acute pain. Any other? One is stone disease, pancreatitis. That's what is crossing my mind. And now it's complicated. That's one. Or he's got a coexisting DU or a GU, and that is presenting as this particular presentation.
Yes.
But yeah.
Any stump leak or collection peritonitis?
Like some, the patient will be very sick. No, they will
Yes,
have
ma'am.
they'll have more of a fever. They'll have more of a lump. They'll be more sick and they'll be acutely ill. Pain may not be a feature.
Okay.
Pain may not be a feature. Not this acute pain that you're describing.
Yes.
And to have a leak after 20 days is little unlikely or less likely, because all these would manifest within few hours or within a day of the surgery.
Okay.
So can you please? Can you? Okay, so I think we'll just move on. So what I want to tell you, Harish, is this. Harish, no, yeah.
Yes,
Don't discuss so much about the vomiting. You know, few minutes to half an hour after food intake with solid intake, but able to take liquids. Unless you're able to give some diagnosis in such a. I'm just wondering, in which situation would you have this particular phenomenon, where the patient gets within few minutes to within an hour of taking food, he has a vomiting. Unless the pathology is somewhere right proximal. Supposing he's got a large pseudocyst in the lesser sac, and that's causing complete compression of the stomach. Maybe then he's not able to eat, and therefore he's modified to the liquid diet. In such a situation, he's likely to have some fullness in the upper abdomen. And what was there in the earlier surgery 20 days back, maybe already had pancreatitis, and that was interstitial, and now just formed the pseudocyst. That's also possible.
Okay.
And no history of abdominal ball rolling movements, awareness of a lump. See, you have to come to a conclusion with this vomiting. What is your conclusion? You're giving 2 negative points, you're giving 2 positive points. What is your conclusion with vomiting?
Ma'am, I was thinking of partial outlet obstruction only, ma'am, considering these symptoms. But patient was having vomiting with solid food, which he was able to take liquid. Right?
But
maybe a partial gastric.
So therefore, don't come into awareness of a lump.
Okay.
Don't mention that. At least you can just say we would notice with the pain, we would notice some fullness, and then he would not be able to take the next meal, and then he would induce vomiting to take the next meal. Then that give us an idea that okay, there is some problem in the outlet, and therefore he's got this particular. And I will come down on the intensity of the pain, and I'll say it's more of a dull ache, and not a severe pain. Okay.
Yes.
And he's modified this, subsided. But and other thing, why do you want to mention this nausea persisted? It makes no sense, no? What do you want to convey by saying nausea persisted? What is in your mind? Vomiting subsided, but because he's on liquid diet, but nausea persisted. You know what will happen? They'll ask you what is nausea. Okay. And then you'll go for a toss. What is nausea? When you get nausea, when will a person have vomiting, but will have vomiting that will stop, but nausea persists? So don't get into so much of a depth, you know. Just say with modification of the diet, the liquid diet, the vomiting subsided. That's it.
Okay.
And then for these symptoms, patient came to our hospital. Okay, next slide. Just move on. I think we've covered this quite well. Now come to the jaundice. At this juncture, so you can just say at this juncture, while he was having this pain and vomiting, he also had noticed yellow discoloration of eyes and urine. That's all. Don't say first urine and then eyes.
Yes, ma'am.
No one will know, no?
Okay.
So many times it's only the doctor who picks up the jaundice. So don't tear apart the history to such an extent. First you notice urine and then you notice eyes. All that is not required. So you notice yellow dispersion eyes and urine within a week of the onset of this particular discomfort post-operatively.
Yes, ma'am.
And now, what are the jaundice? The intensity was progressive.
Yes, ma'am.
Intensity was progressive.
Jaundice is progressive.
Progressive.
Pale. It was associated with pale stools, but no pruritus. It also associated with high-grade fever. Associated.
So the jaundice is not associated with high-grade fever ventures.
Yes, ma'am.
Jaundice is not associated. Just say during the same period.
Yes, ma'am.
Why he had the so the other way of building up the history is suppose the examiner is not connected with you. So you just say that during this time when he had the pain and vomiting and yellow discoloration of the eyes, he also noticed that he had fever with high. Don't bring in associations.
Okay.
What? This particular fever, which is maybe a urinary symptom, how do you know? He's 66-year-old. Why do you want to club the jaundice with this? Just make a blanket statement that there is history of fever with chills.
Yes, ma'am.
Just mention that while all this was happening, there was also history of fever with chills and rigors almost at the same time.
Yes,
And which will often get resolved with antipyretics. That's all.
yes, ma'am.
That's it. Okay. Then say antedating all these present complaints that the patient had, except for the gallstone that was detected during the first admission. There is no history of alcohol consumption. The patient is a teetotaler. There is also no history of any CAM intake that you can mention, nor is there any prodromal symptoms.
Yes.
Okay. So that you can say. Transfusion, tattooing, high risk behavior will not come here. It will come on in your past history.
Yes.
And this other thing, no anorexia but weight loss of 3 kgs over past 1.5 months. What do you want to convey by that? Don't mention that. Just say that while the intake had reduced from a solid diet to almost liquid diet, almost there's been a 3 kilogram weight loss during this period of illness. Finished. That's it.
Okay.
Are you understanding?
Yes, ma'am.
Yeah, don't use this, but no anorexia, but weight loss.
Yes, ma'am.
Weight loss is because intake, the entire food has been modified. No?
Yes, ma'am.
You understood? The food has been modified. Okay, let's continue now. Come on, move on. Just move on. Next slide, yeah. Nothing much, no? You can just skip this. Nothing much there. He's a vegetarian. 1 minute. Vegetarian, previous slide. Anything else? WHO performance state 2. Okay, one thing that you have to mention. Was there any endoscopic intervention? That the treatment history has to come up there.
Yes, no intervention.
1 minute. So you have to say during this period when he was in ICU, apart from an ultrasonographic evaluation, patient did not have any CT imaging. You have to mention that.
Yes,
nor did he have any endoscopic intervention. I'm interested in that. There's an acute pain, and maybe the amylase was elevated, and maybe they found there was a CVD stone, and they would have told the patient, you undergo cholecystectomy now and manage your CVD stone at a later date. So when you finish your present history, you bring in the nutrition that you've already said, diet intake has come down, and then you mention about this particular, during this period of illness, starting from May 25th, during the initial admission in ICU, at that particular point of time, except for regular imaging with ultrasound, he had no major evaluation in the form of the CT imaging, and patient was discharged to undergo cholecystectomy. To some extent, you can mention that.
Yes, ma'am.
And there was no endoscopic intervention either in the form of an ERCP or an upper GI endoscopy. It's very, very important. This negative history you have to make. And if you're not asked for that, you're going to miss the diagnosis.
Yes, ma'am.
Okay, because if this surgeon was seen by a physician, you would have asked for an endoscopy.
Yes,
okay, or in US also. But if it was being seen by a surgeon as the first initial person who has seen the patient, it is likely that you would have said you undergo cholecystectomy, everything is fine, and there's a stone, the CVD. Once you finish this, we'll settle you. This information is very, very, very important.
Yes, ma'am.
The treatment history, okay, that you have to bring in right there in your presentation.
Yes.
Okay, now, yeah.
He did not underwent any endoscopic procedure.
Okay, so any doubts? But BT, you can, I know you're on the train, you can just ask few questions if you can silently.
Yeah, sure. I am listening. I am the train. Right now, the train has stopped. There's not much of disturbance. So, one issue is that this vomiting should not be properly explained. I think the person, the other one possibility of mentioned was there was gastritis. And the possibility is that persons with this so-called pancreatitis, especially acute severe type, may have gastroparesis. And they may continue to vomit because of that. That's another problem. Specifically in the correct line, I think the person had pancreatitis initially, possibly due to also operated, again developed pancreatitis, and possibly due to CBD stones because of the presence of jaundice. I think that's the correct line of thinking. Please proceed. The time is small.
Yeah. Any who are the other people who's with you? Srija.
Srividya.
Yeah. Yeah. Would you like to comment what has been discussed so far?
Yes, ma'am. The history suggestive of
No, we didn't ask the history. We just want to know, have you understood the chronological sequence of events that should be discussed in this patient?
yes, ma'am.
Because what happens is you spend about 5 to 7 minutes with the present, and suddenly we are waiting to see what's happening. We're already writing down in the case sheet, and then suddenly you find that there's something happened just 4 weeks before. Understand? So if it's a continuum of a disease, it's ideal to start with that and then move on. Because you cannot finish this and say no history, and then say 2 weeks back he underwent a lap chole or 4 weeks back he underwent a lap chole. So I think that's very important. Build it like a story.
Okay.
Okay. And then the rest of the discussion, any doubts you have about the way we were discussing about the interpretation? What is your thought process about that vomiting that you discussed so much in detail?
Partial gastric outlet obstruction, ma'am.
Yeah, and as Dr. Vici said, gastroparesis, no?
Yes, ma'am.
It can just be a gastroparesis. Maybe he's a diabetic and therefore he's got gastroparesis, or it is acute pancreatitis and there's sugar obstruction and therefore he's got. Okay, so that's the other thing that you have to consider. And the present jaundice that he has appears to be cholestatic. There is some pale stool and not much of pruritus. So now we'll try to link up the two. Okay. Viti, you have to mute. We can't hear you.
But if they say it is a gastric outlet obstruction, ma'am, the person will immediately come. What is the cause of gastric outlet obstruction? Because it is too short after the second onset of pain. So too early to develop acidosis. So what should be the cause of the partial outlet obstruction?
Yeah, Srividya,
That
you can
will be
answer that.
important.
What do you
I
think?
think there will be lots of early.
Srividya can answer that.
It's a
What
complication of acute pancreatitis which happened 20 days back, and now the patient had most probably developed pseudocyst, and it caused compression of the stomach body or in the some duodenal area, D1, D2 area, can develop this partial obstruction.
Yeah. So
No, that part is agreed, but it's too early to develop that problem. That's the issue. That's it. So most probably during an acute enterobiologic edema, especially in the duodenal splenic also. So that edema is likely to produce a comfortable partial upset. And they're bulking in the pancreas. So these things may contribute rather than having a bulking cirrhosis in the previous or other parts. So we will have to think about this when we investigate the patient. Okay, over to you, ma'am.
yeah. So the other thing that I would like to now, this is one aspect we're discussing: stone, and stone. There's a stone disease and there's a polydocolitis pancreatitis. Now, is it possible 66-year-old male who's got some weight loss, who's got cholestatic jaundice now, is it actually that the patient has got a juxtapapillary growth? Now, just keep a broad mind. Whether there's some other possibility as another differential diagnosis. So supposing, now, if at all he has any pathology, it has to be something very distal. It's unlikely to be in the hilum. Less like gallstone we've already discussed. Is it possible that the patient has got an ampullary carcinoma or a juxtapylori growth presenting as gastric outlet obstruction and now presenting as jaundice? And the whole thing that the gallstone was actually a red herring and had got nothing to do with this because patient has not had an endoscopy. Patient has not had any procedures. Is it possible that the patient has got a dual pathology and actually we are missing on something more than a stone disease? Please keep an open mind. Why I'm saying this is because the diet has changed from a solid diet to almost a near liquid diet. You have to consider the possibilities of a malignant pathology in a patient 66-year-old. Yeah, common things are common.
Yes,
He's not had a CT. We have no information about the ultrasound report, whether there was a stone in the CVD or not. And the pain that he had, we agree, was a gallstone pain. It was a biliary colic, which required a cholecystectomy. But 20 days later, he's having another symptom, which is more of a dull ache and presenting with more as a gastric outlet obstruction
yes.
in a patient. So within 7 days, 8 days, you cannot get a pseudo obstruction. No, you cannot get a pseudocyst formation. You need at least 4 weeks. So I would really not consider the pseudocyst as causing obstruction. Gastroparesis, yes, but even gastroparesis, patient will be able to take solids and some liquids. So in a patient who's now, to me, it is something human that is causing narrowing and narrowing. Is it actually a juxtapylori growth, or is there something around the head of the pancreas that is causing an obstruction, which could be benign or it could be malignant, that is pressing as gastric outlet obstruction? So in my summary towards the end, I will bring in gastric outlet obstruction related to the previous pain and the current pain, totally unrelated to that. So which are the 4 distal malignancies that can present like this? Name the 4 distal malignancies that can present like this.
Ampullary malignancy.
One is ampullary, number 1. Number 2,
head of the pancreas.
head of pancreas. Number 2, distal cholangio, and diurnal juxtapapillary.
Yes, ma'am.
Juxtapapillary. How will you differentiate these 4?
Usually,
I'll just tell. So distal cholangio will present more like raised alphas and gamma GT and pruritus. Jaundice will come on much later. They're all desmoplastic tumors. Head of pancreas will present first with jaundice.
yes,
The ampullary one can present as cholangitis, can present as obstructive jaundice, but juxtapapillary growth is the one that can present as a distal, can present as gastric outlet obstruction with a jaundice that is progressive, and the weight loss is there for 6 weeks. It just started from there, and the weight loss is there, progressive. So please keep that in mind. And therefore, in this particular patient, few important histories. You have to mention about the GI bleed.
yes, no,
GI bleed, very important. GI bleed may be due to pancreatitis, gastric varices bleed due to that. It may be just a ulcerated growth that's presenting more as melena, A, or presenting as fatigue and asthenia, and presenting more as occult bleed. Keep a wide differential. You cannot discuss anything more beyond this because you've considered malignancy on one side, you've considered benign on the side. If it is benign, based on what you've discussed, we will say gallstone disease, a missed retained stone, and therefore it is, and maybe the surgeon has said we'll have the surgery later, and now it is manifesting. So this is first possibility, manifesting now as acute pancreatitis. But it's only 5 days old, 5 or 7 days since the pain has happened. Why should he develop a gastric outlet obstruction? And there's a jaundice. So one possibility is maybe it was missed and therefore he has a mass pseudocyst will come as an important DD. But the second possibility is, are we dealing with something totally unrelated that has been missed? No endoscopy has been done, no high-end imaging has been done. And actually we are considering one other possibility of a distal cholangiocarcinoma. Gallbladder cancer, can it present as gastric outlet obstruction? Yes.
It involves the duodenum as well.
Yeah, in North India, this case was present, not due to polycystic, and we do not know whether the gall. Did he tell the color of the stone?
No, ma'am.
Very important. This question was asked in the DNB exam. Why is it important? Supposing on the table they found that it was inoperable, and they've not told anything to the patient, or they've just done a partial polycystectomy. So most important is this: post-surgery, have they shown you the stone? Have they shown you the gallbladder? Because if it is a white stone, cholesterol stone, then the GI risk of gallbladder malignancy is very high. Whereas down south, the pigment stone and mixed stones, bile is less lithogenic, gallbladder cancer is very, very low, 0.02%. Very, very important. This question was asked by Dr. Vivek Saraswat in one of the DNB examination. What was the color of the stone that was disclosed by the patient? So did you get that information?
No.
Very important. Because then you will know that yes. And you should also ask, did you get the report of the histopathology? Very important, no? He has to go back to the hospital to know whether the histopathology was normal. Did you ask that?
No, ma'am.
So these are the most important, crucial histories that you should ask in a patient. Now, because my mind is working towards malignancy, I would definitely ask for this history because my mind is working. Why should this fellow now have an obstructive jaundice? So then my mind works. Are we missing actually that gallbladder cancer that was there, that was mimicking and has a gallbladder cancer with a stone disease presenting as this thing, but it's actually not gone back to find out what the histopathology is. Are you understanding?
Yes, ma'am.
Yeah, so the discussion will not just stop with a simple case of gallstone disease, pancreatitis, pseudocyst, gastric ulcer. No, do not stop like this. Here's a patient, 66 years old. He's old. So for me, malignancy will also come up high on the list in this particular patient. Who's the third participant? Srijan?
Sujit.
Sujit.
Yes, ma'am.
Any
Yes, ma'am.
comments? Yeah. Any doubts you have? Because if the exam actually, the history is good,
Yes,
then
ma'am.
after that is very simple. So now now I know what I'm planning to see on examination. That's all. And investigations, I just need 1 or 2 to make my diagnosis. So now tell, any suggestions you have or any comments you have to make on the history taking?
No, ma'am.
You can openly you can just discuss. If you have a doubt, how would you have approached? You can discuss, no problem.
Ma'am, I have a doubt now.
Yeah.
Ma'am, this patient was if the initial pathology, if you are suspecting malignancy, he should not have improved after the surgery. The patient was apparently already 20 days.
But the weight loss is persisting.
Yeah, weight loss is there.
Weight loss is persisting. Actually, the weight loss of 6 weeks actually took me back to that 6 weeks.
Yes.
I was wondering, why did he have a weight loss of 6 weeks? You only brought that history 6 weeks back. For 6 weeks, there's a history of weight loss. So why should a person with gallstone disease have a weight loss? After pain, yes, because then they don't eat. But if the onset of illness was with a weight loss, then to me, malignancy will come in, and in that I would consider. But please always don't consider only benign. But my suggestion is, you have to keep an open mind. Are we missing something more beyond than what we're talking of gallstone disease? Because to me, within 5 days or 6 days or 7 days of onset of the second pain that you described, I can explain the jaundice, fluid collection, there's some stricture formation, yes. But to me, I cannot explain the vomiting. I'm not able to explain the vomiting that you described so much in detail. Unless there's a collection in the duodenum that is compressing the second part of the duodenum, presenting as gastric ulcer obstruction, which is a valid point. Okay? Okay. So now summarize. Give a good summary.
Here is a 66-year-old male patient who...
Change your slide. Yeah.
66-year-old male who underwent a laparoscopic cholecystectomy 30 days back for a possible biliary pancreatitis.
They won't undergo surgery lap chole for a biliary pancreatitis, no?
Yes.
Look at the way this is good way that you present it on your own.
Yes.
Will you undergo a lap chole for a possible biliary pancreatitis, which manifested as?
Yes.
He underwent lap chole for a symptomatic gallstone disease with a possible acute pancreatitis, acute severe pancreatitis, because he's in ICU requiring oxygen.
Yes, ma'am.
So acute severe pancreatitis, yeah.
Now presented with
Asymptomatic thereafter for 3 weeks or 2 weeks.
yes, ma'am. Asymptomatic for the next 20 days. Now presented with pancreatic type of pain associated with.
Don't use the word pancreatic type of pain.
Okay.
Dull ache. See, one side you're saying dull ache, other side you're saying severe pain. Now just decide what you want to tell.
It was severe only, ma'am. And that's what he told me. The word.
So with the pains simulating acute pancreatitis, okay,
Yes.
with polystatic jaundice.
And yes, ma'am. With fever.
With fever. But no, they say it performs scale of 1. Yeah.
1.
So now, what's your syndromic diagnosis?
So syndromic diagnosis is extrahepatic biliary obstruction.
Syndromic diagnosis will be post cholecystectomy status.
Yes, ma'am.
We'll start from there.
Status post laparoscopic cholecystectomy.
Uneventful recovery.
Sorry, ma'am.
Uneventful recovery.
Uneventful recovery.
Okay.
Now presented with
extrahepatic biliary obstruction.
With possible partial gastric outlet.
Complicated by partial gastric outlet obstruction. No comorbidity, but the performance scale of 1.
1.
Now, what are the causes of the polystatic jaundice complicated by polystatic jaundice? So what do you think? Now describe both of them. Why do you say patient's got EHBO? And why do you say he's got gastric outlet obstruction? Discuss both.
My first possibility I am considering as infected pancreatic fluid collection, ma'am. Considering the severity he had initially, so I will put off pancreatic necrosis collection rather than.
Doctor, but 3 weeks he's been normal, doctor. After that, 3 weeks, 2 weeks, 20 days, you said he's normal, no?
Yes, ma'am.
If he's got pancreatic necrosis, he'll not be normal, no? What is likelihood? What is the more likelihood? First will be a retained stone, no?
Retained stone.
First will be a retained stone.
Yes, ma'am.
Retained stone, maybe it's now got into the ampulla, pressing with one other pain, now pressing as acute pancreatitis. So that's how it will be.
Yes.
And maybe there's a fluid collection with a gastric outlet obstruction. That will be your first. That will be your first. And you can explain the cholangitis as well.
Yes.
Okay, but the infected peripancreatic fluid collection I will not consider at all in this particular patient, presenting as gastric outlet obstruction.
Okay.
Because he's been asymptomatic, he's gone back to his routine work with no symptoms, nothing else is there. The second is only a pain. So it's a CBD stone pain, resilience pancreatitis with a fluid collection can explain everything. The second possibility, you have to consider the possibility of a missed malignancy. You have to consider other causes of gastric unrelated to the stone disease. You will call it as unrelated to the stone disease.
Yes,
I would like to consider EHBO either due to one of the 4 distal carcinomas, as a head of pancreas, juxtapapillary, ampullary. The distal cholangia will not be as a DD. That's all. Bile duct injury, how do you explain?
I was considering any bilioma formation or something, mass causing outlet obstruction.
They'll feel a lump. No lump will be felt.
Yes,
A biloma will present as a mass.
okay.
Yeah. And do you think that the patient has gone to see the doctor, his own surgeon, after the surgery?
Yes, ma'am.
And the doctor said everything is fine. So less likely, at least you would have asked for an ultrasound. Would you ask whether he had an ultrasound during that time, 20 days when he had that first pain?
No, like in the hospital he had ultrasound, but he does not know the reports. Post surgery, he did not underwent any.
Okay, no, he went back to the surgeon. No, did the surgeon ask for an ultrasound at that juncture?
Now, ma'am, before current presentation, he has gone back to like this 10 days pain. He has went to the surgeon. He investigated him with like further investigation that I have kept next.
So what is your comment, Shinja? By any other differentials you'd like to offer?
You'll also consider
Sujit and
Madam, can we consider one is post-lab coli, he was given some medicines, so a drug-induced, the second event of pancreatitis could be a drug-induced pancreatitis.
No, which drug would you give for a patient who is otherwise normal, no? Post-op. Post-op is normal. Post-op is normal. It's normal for 3 weeks, but he gets one more pain, indicating more of a retained stone or a stone that is spilled out while doing the polycystectomy. That's more likely. That is more like a retained stone. That is caused all the problem, but not NSA related. NSA related will not present. It can present as vomiting, but not the gastric stasis. So NSA will not come as a DD. But just remember the 66-year-old male. Just remember this: that the malignancy is being missed.
Yes, ma'am.
Okay, Shrija, Shrija.
Yes, ma'am. Nothing else. Malignancy should be considered.
I think you have to keep. You must keep one possibility of a malignancy. Okay, can we move on?
Yes, ma'am.
coming to the examination.
Just check the important salient points.
Icterus is present, ma'am.
Deep, is it? Deep?
No, ma'am, not deep.
Okay, so icterus is present.
Icterus is present.
So in this particular patient, you look for the nodes, just in case you miss the nodes.
Okay. No lymphadenopathy, ma'am. So, abdominal examination.
What are the important points, positive points? Just tell me, positive. Then go to the palpation. Yeah.
Yes, ma'am. Laparoscopic scars were only present, ma'am, on examination. Palpation, there is an ill-defined mass in the epigastrium, extending about 10 centimeters below the xiphus sternum, and lateral extent was about 15 centimeters. Upper borders were behind the costal margin. Rest of the margins were indistinct. It was smooth surface, firm in consistency, mild tenderness on deep palpation, does not move with respiration. There was no pulsations, fluctuation test is negative. It was less prominent on leg raising and no increase in prominence in left lateral position.
So when you found on examination such a big mass,
Yes, ma'am.
then the whole presentation you just said, you also notice fullness, no? How does it matter to you whether you're conveying the message or not?
Okay.
You understood?
Yes, ma'am.
When you found that there's a fullness in the upper portion of the abdomen, and you've been able to almost, it's not well defined, but there is ill-defined mass, but you're able to pick up the mass.
Yes,
Just have to bring it in the history saying that he has noticed fullness in the upper abdomen. Over the next, initially 10 days, 15 days, he was normal, but subsequently he noticed there was a fullness occurring in the upper portion of the abdomen. And this caused a little bit of ache. And as a result of this, he found that the intake, he was having fullness and early satiety on eating. Bring up the history in that manner.
Okay.
Don't tear upon the history in such a way that you keep the exam. That's what I said. The trump card is with you. The trump card is with you. So when the trump card is with you, please play it on the table and say that he had discomfort. Then it can explain the whole thing. No? Now it's easier to discuss.
Okay.
And it's easier to discuss. And then in your summary, you'll say that while he was recovering well, I'll put it like that. He noticed that over a period of next 10, 15 days, he noticed some fullness in the upper abdomen. It was steadily increasing. And over a period of time, when the intake of food was good initially, we found that the intake became less and less to the extent that now, that's how he built up the history. And then say that his intake became less and less, and to the extent that now he's able to take only liquid, then it's easy to explain everything. Then in your summary, you'll say that probably he's developed a fluid collection, evolving pseudocyst, causing compression of the stomach, causing early satiety, nausea. Then the whole everything. And then you can explain the jaundice in this particular patient could be due to compression of the CBD. Finished.
Yes.
Are you understanding?
Yes, ma'am.
In this particular patient, if he has an acute pain, they will think of hemosuccus pancreaticus. You have to consider other possibilities that can happen. That's what I'm telling. Again, please don't keep the examiner guessing. Once you've examined the patient, in this particular patient, you know what I would have done? I would, as if the patient came to the OP, I'd first make him lie down. And just once I start palpating, I'll ask the history. I've got the scar. What happened? And then whole history, I'll just build up towards the lung. That's it. I'll not waste my time at all breaking my head for anything. It is such a straightforward case, no? Otherwise.
Yes.
Doctors, again, I want to tell you, all those who are listening, just be very careful, try to build up the history in such a way that you direct your questions towards your case. And it's easy for the examiner to question you in that direction. If you keep the examiner guessing, you'll end up in more problems. All these questions that I asked, color of the stone, did he have retained stone? All these questions will come up. You understood?
Yes.
Now would you consider malignancy as a possibility? Less likely or unlikely?
Yes.
Unlikely. Now, so what? Palpation, percussion, anything? Positive? Nothing else. So everything else is normal. So now other systems are normal, no?
Yes, ma'am.
Okay, so now what's your final diagnosis?
Status post-laparoscopic cholecystectomy, uneventful recovery. Now presented with.
No, final diagnosis. You're writing the prescription.
Yes, ma'am. Status post-laparoscopic cholecystectomy, possible biliary pancreatitis. Now presented with peripancreatic fluid collection, possibly infected, causing
Why do you say infected? I would say there's a stone in the CBD causing cholangitis. Why do you say patient's not toxic? No, is he toxic?
Ma'am, he has been given IV antibiotics before referral, ma'am. At
That's
the onset
okay.
of fever,
So the fever can be due to either the stone with cholangitis or it
can be because of the infections.
Yeah, so keep both the differentials in mind.
Yes, ma'am. Complicated with maybe possible distal CBD obstruction causing cholangitis, possible cholangitis.
Retained stone, no? Polydocholithiasis. So now your diagnosis will be post-polycystic status, polydocholithiasis, retained stone, that is most likely, which has been missed earlier, which has slipped during the procedure, with acute pancreatitis, which is complicated with fluid collection. manifesting as partial gastric outlet obstruction
and obstruction.
and obstruction to the biliary system. That's it. That's all. With a performance scale of 0.
0.
So how will you proceed to investigate this patient? Sridhar, is she with you?
Yes, ma'am.
So,
In blood investigation, I'd like to
so
get.
now, Harish, do you think now it is a problem of surgery? Do you think it's complicated by surgery? Unlikely.
Unlikely, ma'am.
Unlikely or less likely? Unlikely. And the other one that you said, and the first differential you said was pancreatic necrosis or something. That infected necrosis, you'll not say. Now it is more of a fluid collection because it's not yet 4 weeks. Yeah. And what will be the grade of pancreatitis? What will be the severity of pancreatitis? That you have to mention here. Your Atlanta classification.
Yes, ma'am.
Mild, moderate, severe?
It is a moderate, ma'am. As stage moderate, ma'am.
It's moderate. BT, will it be possible for you to speak?
Yeah, because they mentioned about infected pancreatic fluid. Because infection occurring in and around pancreas usually happens after the second week of an acute pancreatitis. So before that, it is even if there is fever, it is due to the systemic inflammatory response. So in this case, there is silks and rider. So we have to consider cholangitis because there is bringing in infection of this fluid or fluid. The operation is done. This has to be sort of when you just infection and pancreatic fluid. That's the point I want to highlight now.
So hang on, because the pain is there, hang on to cholangitis and just mark down on the necrosis, no infected necrosis. It will not happen. It is not, you yourself, it is not severe, no? So Srividya, how would you like to investigate this patient quickly? Just tell this out.
In blood investigation.
Level 1 investigation, this patient will be?
Blood investigation, routine blood investigation, complete blood count.
Yeah.
In that, since the patient is having fever, I want total count to see the cholangitis. And then the renal function and the urea and creatinine I want to see any organs function is there. Then liver function, LFT.
Liver biochemistry.
Liver biochemistry. In that, total bilirubin, direct bilirubin, alkaline phosphatase, and
gamma GT.
Gamma GGT.
Yeah. And you expect a near normal albumin and globulin. No, this will be. And what about your pancreatic function? Pancreatic enzymes.
Some amylase and lipase.
Yeah, and calcium.
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 You'll ask for serum calcium. You'll ask for amylase. You'll ask for lipase. Lipase more than amylase because now it's almost a week later. Okay, so these are some of the basic investigations we'll ask. So what do we have? We can just go through. So there is leukocytosis.
Abdominal total count is 17,100. Then
creatinine is normal. LFT, comment on the LFT.
Bilirubin total is 5.2 and direct 3.61. So the direct hyperbilirubinemia is there. Alkaline phosphatase is 160. It's elevated.
Mild elevation.
Elevated.
Are you surprised with the AST-ALT?
AST-ALT is 35 and 40.
Yeah, so there's not much. You know, so the jaundice is just there. Now, just before that, just think now it's 3 weeks. He's still in the incubation period for a hepatitis. So just keep that also in mind. Just keep that in mind. But here the enzymes are normal, so unlikely there's any reactivation of a hepatitis. But a little surprising, alphos is not very high. It's not very high. Okay. Hemoglobin is 11.6. Okay. Next investigation. What would you want? What do you want?
Ultrasound abdomen. I want.
Yeah, ultrasound would be the next investigation of choice.
See the stones, CVD stones, CVD dilatation.
That you won't pick up, no, with such as fluid cirrhosis. Here you just pick up what you pick up will just be a fluid collection. Pancreas may not be visible at all, but level 1 investigation should be an ultrasound scan. And if creatinine is normal, what will be your next investigation? High-end imaging, because now you need to sort out what it is. You ask for
CCT abdomen or MRCP?
No, not all. You just tell which one would you want and why. You ask for MRCP with
MRCP with MRI if we are suspecting Waldorf necrosis, pancreatic necrosis is there. For that, MRCP is better. And for also,
MRCP, yeah, you can pick up the stone also. No?
Stones also, MRCP is better.
You'll get the ductal anatomy because there was one possibility, he said ductal injury, which again you can pick up with MRCP. So you will need an MRCP. And for this end, the pancreatic end, ideal would be just to complete it with an MRI Or you want a complementary, you can do a CCT. What about EUS at this juncture? EUS?
EUS,
It may give you all the information. No?
yes.
EUS will give you all the information. You do an EUS, you'll get what's happening to the CBD, you can see the distal CBD, you'll get an idea of what's happening to the stomach, you'll get an idea of what is fluid. So in a sense, don't discuss about any centers. Now between the three, which one would you choose?
If US is available, US.
Not availability. No, that's what I say. In exam, don't discuss about availability. You're in the best of centers with everything is available. You have
Then-
all the expertise. Everyone is an expert in the center, given center. So in a given patient imaging, it's better. 66-year-old, it's nice to have a cross-sectional imaging.
Then MRC,
And then for
MRI
MRI
with
with MRCP. And then for management, maybe you can take up the EUS. That would be my way of thinking. Okay, can we have some information? Needed? Harish, sorry. Yeah. You can discuss, read it out.
MRCP has been done,
Yeah.
status post lab cholecystectomy.
Mhm.
Small T2 hypointense foci in the distal common bile duct. Possible calculi with no significant dilatation of the common bile duct. Mild fatty liver with cyst and calcific foci. A well-defined irregular lobulated heterointense collection, probably communicating with the main pancreatic duct. Mildly bulky head and uncinate process of the pancreas with peripancreatic inflammation. Features suggest of walled off fluid collection, probably communicating with the main pancreatic duct.
Now,
And,
this was done when?
this was done at current presentation. After this
Current
MRCP, patient has
presentation,
been referred to.
Come here. Okay. So what's your comment, Srividya?
So it's heterointense collection communicating with main pancreatic duct. So it is walled off pancreatic necrosis, and it's showing a well-defined wall. So walled off pancreatic.
Yeah, but we need to know that huge mass he found, no, 10 into 8 centimeters. We've not got that information. So we need that. No, he found a mass on palpation. So we need an MRI imaging. On examination,
Yes, ma'am.
the patient had a mass, no, 10 into 8 centimeter mass. So that will not be picked up with MRCP. So can we have some more imaging information? Any imaging
We did
information?
EUS for this patient, ma'am.
See, that's what now they've done an EUS.
Next will come.
Okay, can you describe the EUS?
Next slide.
EUS, can you just tell the EUS? No,
Ma'am,
don't do this. No, so okay, tell what's the EUS finding. Yeah, tell the EUS finding. Tell us the EUS finding.
shall I describe now? Yes.
Show us the EUS. Tell us the EUS finding here.
Ma'am, this is the EUS has shown a large collection, ma'am, about 8 into 8 centimeter collection,
Yeah.
heterogeneous, with the solid component greater than 50% in the body region of the pancreas.
And this was where was the EUS placed? In the antrum?
Ma'am, this
It
is
was-
yes, ma'am, from the antrum only.
Antrum, because there was probably a narrowing in the duodenum.
D1, D2, there is some narrowing, ma'am.
Narrowing is there.
Yes.
So there is a narrowing.
There is
Can
a
you
narrowing.
Can you just tell the endoscopy? Yeah.
Yes, ma'am.
Good. Endoscopy finding, just tell us what was the finding?
Ma'am, stomach was congested mucosa is there. D1 was dilated. Luminal narrowing at D1, D2, but scope was able to pass through without resistance. D2 was
So
narrowed.
you just see, this is what I said, no?
Yes, ma'am.
The patient has got obstruction of the duodenum. This is exactly the way you have to discuss in the exam. Until the examination. Up to the examination, you have to consider all the possibilities. But once on examination, you find a mass. So he should have played low on the pain and discussed more of a vague discomfort in the upper abdomen with a visible, fullness that is noticeable by the patient. Then the entire thing, it's easy to discuss. Then we discussed, that can present obstruction to the CBD, can obstruction to the duodenum, second part of the duodenum, because patient is having partially that. You understood?
Yes.
That history is very important there. Build up the history to bring in the fullness, early satiety, fullness, nausea, vomiting. So then you can direct the examiner towards a complication of a CBD stone with a gallstone disease rather than consider one other possibility. If you do not discuss about the mass and the fullness and the early satiety, you will have to discuss all other differentials in this patient, including malignancy. All right?
Yes.
So now, Sujit, how will you manage this patient? You've done an EUS
Yes,
and you
ma'am.
found that mass. So what should you do?
Ma'am, first would plan for since there is a extrinsic compression to the stomach, would
And patient is symptomatic.
and
Patient is
symptomatic, he would require drainage of the pancreatic cyst. So, if possible, we'll do a US guided cystogastrotomy.
And along with gastrostomy, what else would you do?
Along with that, a placement of a lumen opposing metallic stent, and if required, a lavage and maybe even a necrosectomy.
Sure. So that will be the way forward. And what about the CBD?
Uh,
One
Yeah.
minute. 1 minute. So, Sujit, what should you do for the CBD?
The CBD, he should also undergo simultaneously an ERCP and
You'll not be able to do ERCP, no? How can you do an ERCP? You're not able to reach the second part of the duodenum.
Scope was able to pass, ma'am. Just luminal narrowing is there, but scope
That's
was
okay.
able to.
That's okay. Now, 1 minute. Do you want to intervene? The alkaline phosphatase is near normal.
yeah,
And AST, ALT is near normal. So what would you do? I would wait.
then
I would wait. I'm not in a hurry at all. If MRCP has not shown any other problem, then once the necrosectomy comes down, all the necrotic material is removed, you're likely to have less and less compression, unless now the patient is going for a stricture of the CBD. That you can wait.
yes, ma'am.
Right now, the management would be only this. So, can you just discuss, Harish, what happened? Yeah.
Ma'am, this patient on EUS, we found a distal CBD calculus is also present, ma'am.
That's
But-
what that means.
but there is
that
no
we thought it
dilatation.
is. So we thought that that's what. So for the exam, just read what is retained stone, what is recurrent stone. Okay, all this you should know.
So,
What is retained?
we
Retained is the same sitting. Recurrence is after 2 years or 6 months, I think. So just read what is retained, what is recurrent.
And like we have done ERCP, and in the cholangiogram, we also found a mid CBD stricture was also present, ma'am. So we have removed the stone and we have placed two plastic stents for the stricture, so that we can.
Yeah, but otherwise, what this is too much of an adventure. But since the patient has a stone with a distal CBD, you have to do an ERCP,
Yes,
no?
yes, ma'am.
Because otherwise it's going to worsen the pancreatitis. So first will be a necrosectomy, allow the compression on the CBD to come down, and then tackle the stone again with an EUS, okay, with an ERCP.
Yes,
Then ERCP, and it was, I think, a black stone, no?
yes, ma'am. Pigmented stone.
Pigmented stone. So the gallstone would also be pigmented. This is what is most commonly seen in southern parts of the country. So I think that's a way forward in this patient. That's why Srividya just, so in a given center, when everything is available, just see, you have to, the cost has to come in. So you'll have to save the money, at the same time do the best for the patient. So here the main aim was to decompress this huge thing so that the vomiting becomes less. This problem is not able to eat. So once you decompress this, the stomach will expand and you'll start eating. And you can even wait and then do the ERCP at a few days later and then remove the stone in the distal CBD. Okay? Harish, you did it in the same sitting, huh?
It was done in same sitting.
Yeah, so it may be a little too complicated for the patient who's 66 years old. I would rather wait for some time and then allow the whole thing to decompress and then tackle the stone. Okay, any questions you have? This is the way the exam would go on. This is the way any questions anyone has? Are there any questions in the chat box? What will be the long-term follow-up and what is your comment on this stone causing such severe pancreatitis? How often do you get this distal stone causing acute pancreatitis?
We do see, ma'am, it's not uncommon. Patient.
No, in your 3 years, how often have you seen alcohol-associated severe pancreatitis versus stone-related acute pancreatitis?
Alcohol is definitely more common rather than gallstone pancreatitis.
No, you have to give numbers, you have to give figures. So just read Pramod Garg's papers. You'll get a lot of information on the prevalence of severe pancreatitis, acute pancreatitis related to stone disease, as well as alcohol. So just read all those other theory parts as far as this case is concerned.
Yes.
Okay. Any other questions? Sujit and Srividya?
No.
So I think all the questions that you addressed, just go through it, okay? Because I don't have another person to discuss it. Can we go to the second case quickly? Yeah, quickly. Who's presenting?
Purva.
Yes, ma'am.
Purva, okay, come.
Yes, sir.
Harish, you can take up a discussion. All
Yes,
three of you, yeah. Purva,
Yes, sir.
present.
Yes, sir. My patient is a 32-year-old farmer, a resident of Nashik, who came with chief complaints of repeated episodes of hematemesis since 15th of July 2022, last episode being on 20th of August, and abdominal distension and pedal edema since the 21st of July 2022.
You have to be a bit slow, okay? Be a bit slow, okay.
Yes, ma'am. Yes, ma'am. So the history dates back, the chief complaints are from July, but the history dates back to the year 2004 when he was about 15 years old. So he experienced the first episode of hematemesis, which was in the form of large quantity of fresh red blood with clots, without any preceding fever, vomiting, retching, drug intake, abdominal pain, and it was associated with giddiness and palpitations without loss of consciousness or syncope.
Now, how would you remember that in 2004 he had palpitation and all giddiness? No, giddiness is okay. Palpitation
Yes.
and all. Do you remember
Giddiness.
what happened to you at the age of 14 years?
No,
No, then you won't remember anything.
Yes, ma'am.
Don't make it so this thing that how will a 14-year-old boy know what is palpitation?
Yes, ma'am.
Just say that he had vomiting of blood. That's all. Very
Yes, ma'am.
simple. At the age of 14, in 2004, patient had the first episode of vomiting of blood.
Yes.
That's all, which required hospitalization or whatever
Yes.
was. That's all that you have to say.
Yes, ma'am. So he was hospitalized, given blood transfusions, and he had undergone a therapeutic upper GI endoscopy with band ligation. Thereafter, he had experienced 2 to 3 episodes of tarry black color stools, which was self-limited and did not require any further blood transfusions or a repeat scope. And subsequently,
No, that what do you want to convey by the previous after the endoscopy? What is that? 2 to 3 episodes of
there's a collected blood was just he just had a
So
malignant.
don't mention that. No, the way you're describing experience 2 to 3 episodes of tarry blood stool, is it during the same admission?
Yes, ma'am. During that.
So don't mention all this.
Okay, ma'am.
Don't mention all this. We're not interested at all. No, you will have melina for 8 days. No, the longest period is about 8 days after one bleed.
Yes, ma'am.
Okay.
That means I wanted to convey that the episode was self-controlled with the controlled with the one episode.
That's all. So just say he had a bleed in 2004. Patient had bleeding and vomiting of blood, which required hospitalization, blood transfusion, and during that procedure, during that admission, patient had undergone an endoscopic procedure, which was most likely a band ligation. That's all. Nothing more to be explained there. Don't say melina continued for 3 days, 4 days. Okay.
Thereafter, from the year 2004 to 2019, he had repeated episodes of such unprovoked hematemesis, which required hospitalization, upper GI scopy, and the blood transfusion.
Either you know that it is 5 times, or it is 10 times, or it is 12 times, you have to mention. If it is 20 times, then it will be several episodes. But if it is just 2 or 3 episodes, you may have to describe each of the bleeds.
Okay, ma'am.
So, from your history, how many episodes of bleeding had?
Ma'am, approximately one episode a year he used to get.
So that is about one episode. But each time he was hospitalized and banding, not possible. It's not possible. It is not possible, no, that every year he goes to the hospital and has a banding. Somewhere the banding has to reduce the size of the varices. Be very careful with such comments, no, the history taking.
Yes, ma'am.
If a person had the first episode in 2004, you have to tell us unprovoked vomiting on an average of at least once a year, requiring hospitalization, requiring transfusion. Was it like that? Requiring banding? Is it like that? That's what. So now you're not able to answer that. So we need to know that, no?
Yes,
I hope you're understanding. If there are several episodes, then you say several episodes. But we need to know whether the patient required hospitalization for these episodes and what was done on each episode. If a person has that many episodes, some surgeon would have done a shunt procedure and been done with it.
Yes, ma'am. Yes, ma'am. He was evaluated in 2016, but investigations were also done, including a liver biopsy. But he used to, as soon as the symptoms were relieved, he used to be lost to follow-up.
So your first history of GI bleed is wrong, okay? The GI bleed history is not okay. You have to give us that particular information. No patient from 2004 to 2022, that is 18 years, has recurrent episodes of bleed with nothing happening to him. Okay? It's not possible. They will have 2 or 3 episodes over the last 22 years. They will not have every year they'll have a bleed and they have 22 episodes of bleed and nothing has happened to him. No doctor has taken charge of him. It's not possible. So somewhere down the line, the history is wrong. I hope you all are understanding what we're trying to convey. You have to be very clear in your presentation. And such patients who have 1 or 2 or 3 episodes, either EHPV or NCPF, but they will start decompensating by 4 to 5 years to 8 years. They'll develop an NCIPH or EHPVO will progress to develop collaterals and they'll die of liver steal syndrome. They'll go into encephalopathy and they'll die. 22 years is too long a history for a patient to have several episodes and nothing is happening to him. There's some problem with the history there. Okay, continue.
After these episodes, there were 3 or 4 episodes of progressive uniform abdominal distension followed by pedal edema occurring after these hematemesis episodes without any abdominal pain, oliguria, shortness of breath, orthopnea, PND, and it was managed with oral medications and used to resolve. In the year
when you get the situation, that is after a bleed, you can get transient.
Yes, transient ascites.
Transient ascites. That's also don't make it as a big history.
Okay.
Yeah, it is not a huge history. That a very important history. So post bleed, patient would have a transient abdominal distension, which would resolve once a blood transfusion is given. But that's very important. Your history there is gone. That blood transfusion history. I'm not clear about it. Okay, then what happened?
In the year 2016, he was evaluated with blood test, urine test, and abdominal imaging in the form of CCT, and a liver biopsy was also done. However, he is unaware of the findings that were told. And since the year 2018, he has complaint of pain in the left upper abdomen, insidious onset dragging type of pain, continuous and of mild intensity with no referral or radiation, and does not require any medications, no aggravating or relieving factors. The patient had been on certain medications for preventing the bleeding episodes, but he defaulted those on his own since the year 2017. It seems from 2017 to 19 he was asymptomatic, and in July 2022 there was another episode.
So just what I want to last time also you had the same problem. Your history taking has to be sharpened. Okay, the history is becoming monotonous. No? So what you have to say in a patient like this, you just make it very simple. Summarize this case, that will be the history. Summarize. Just summarize.
I'm 34-year-old.
I just want to convey this message. No, don't say you had bleed, then you stop. Again you had a bleed. Again you had ADVL. It becomes monotonous for any examiner to listen or for anyone to listen. So you have to make it very crisp and short and say patient until the age of 2004 was a young boy who was attending classes, attending school with no symptoms, and he was doing very well. Then for the first time in 2004, he developed noticed vomiting of blood, which is also associated with passage of black colored stools, which is as per his recall, that is his recall, for which he was admitted. And with the help of his mother, it came to understand the patient was admitted and also required a banding. Subsequent to this particular episode of the first index bleed, patient was otherwise fairly doing well until 2022, except that there were few other episodes of GI bleed, which again required hospitalization and would often settle down with blood transfusions and endoscopic intervention. And this continued for the next 18 years. During each of these episodes of bleed, you would have a transient decompensation in the form of ascites and abdominal distension, which would subside within a day or two and patient would get back to routine. During this time of 18 years, he also had a visible mass appearing in the left side of the abdomen, which had a characteristic dragging character. And more recently, there is some pain in this. That is all that you have to tell, so that you build up the history to convey the message that there is a bleed. It is a varicose bleed at the age of 4. And now it is 22 years. We just have to distinguish 2 important causes of this recurrent GI bleed. That is all. What else can happen in such a patient? Jaundice. So important is, can this patient develop total cavernomatous cholangiopathy? That's all that you have to highlight. Did he develop jaundice during this time?
No, ma'am.
And
That
you
was
know that EHPVO seldom progresses to liver disease, cirrhosis, etc. It is unlikely or less likely it is a case of cirrhosis, because cirrhosis for 22 years will not continue like this. So your DD is shortlisted to NCI-PH or it is
Or
EHPVO.
EHPVO.
That's all. In NCI-PH, 20% can progress to cirrhosis. Then you have to say that currently, though he's had these bleeds, there has been no history of long-standing abdominal distension, oliguria or distension. There is, except for the dragging pain, there's been no pain. There's no history of jaundice. This is more important. And that's all that you have to highlight in this particular case. Okay. Look at the history, no? Experience 2 to 3 episodes lasting 20. What I've summarized is what is your history taking?
Ma'am, actually,
Yeah, tell me.
so 34-year-old male patient with a history of repeated episodes of unprovoked hematemesis,
So
followed by
just go back. So don't bring in so many no histories.
okay.
Jaundice is most important, that's all.
Okay.
Okay, failure to thrive, delayed puberty and all. EHPVO, yes, but then when you suppose you see the patient in front of you and there's a growth percentile reduction, then your diagnosis is EHPVO. But they will not have large spleens. EHPVO patients do not complain of a
Yes,
dragging pain.
Yes, ma'am.
I understand. So that history will not be there. So it's easy. Now, one other differential is congenital hepatic fibrosis. That's one other thing. But they're all less than around 4 to 5 years of age. They don't manifest at the age of 15.
Yes.
You understand? So if on examination you found a hard liver, the stony hard, it's called as hard as a marble in a congenital hepatic fibrosis, then you can bring in that particular information in your history taking that there's a discomfort in the right hypochondrium. But if it's not there, no need for disclosing that.
Okay.
Okay. No history of abdominal movements, sensorium, altered sensorium, all these you have to just make it as a brief summary and just say that otherwise patient was doing well, he completed his schooling, he's attended his college, or he's gone for a job. That is what you have to convey to us. So what happened? He completed his studies and went to college and all that?
Ma'am, he was not very well educated. He's only educated to
No, but
7th
is he
class.
working? Is he working?
Yes, ma'am. He's working as a farmer. Because
So he's able to work as a farmer, no? So he's working. So his performance scale is good.
yes.
Okay, any comments, any doubts you have in a patient like you, Sujit and Srividya and Harish? How you have any doubts as to how to present this case? Please ask, because this is, I want you all to improve on your history taking.
Ma'am, I had one question, ma'am. So patient was okay for the last, he had these episodes of bleeding, then he was okay intermittently, and now again the episodes have started without any provocation. So should we think of some precipitant in this case, which could have led to it again, or just that he has not been taking his medications and that would have been
All that is for discussion, no? That is for your discussion. But if you find that he was asymptomatic for, say, 2000, he was asymptomatic for next 10 years, but last 1 year, after 10, 15 years, he has one bleed, then all of the cause of bleed have to come in your mind. Whether it is DU-related, GU-related, drug-induced, is it some other cause? Those differentials will come in. And of course, default of medication. But very, very important, no patient can present with 24 episodes of bleed for 22 years without investigation and without any treatment. So do you have any doubts, three of you? Can just ask.
Ma'am, in this patient had pedal edema and abdominal distension also in presenting complaint, which lasted for some few days.
That's what we said it as transient. No, it was just transient post bleed.
This time it was a bit more.
Yeah, that's okay. That's for discussion. No, then we'll say that that's a natural history of NCI-PH. No,
Okay.
in NCI-PH, the natural history will be 20% can progress to cirrhosis.
Okay.
So that we'll just take it as discussion. If current one continues with an ascites with oliguria and edema, that means now there's a progression to cirrhosis. Then we discuss etiology and other things. That's a different history. Any other doubts that you have, especially in patients like with recurrent episodes? How to go about presenting?
Ma'am, since this patient has like an ascites, usually won't it be a transient, like minimal ascites in NCP?
That's what? That's what we said. It is after a bleed, no? Or in 10% with NCIPH can have ascites.
Usually,
We said that.
yes, ma'am.
But in case they progress to cirrhosis, which has been described by many of us, then they'll manifest as cirrhosis. NCIPH progressing to cirrhosis, presenting as cirrhosis. But that's the natural history of NCIPH. One is transient bleed, and you know that 10% of 20% of patients with NCIPH can also have ascites. That also is well known, as you said. What you said is right.
Yes, ma'am.
Even in a kindergarten case of NCIPH, 10 to 20% can have ascites. Because as far as the liver is concerned, it is not true pre-sinusoidal. It is peri-sinusoidal. The NCIPH doesn't stop with the pre-sinusoidal. It spills over to the sinusoid. So it is a peri-sinusoidal. That is why you get a larger liver, and you also get 10 to 15% presenting with ascites. Okay?
Yes, ma'am.
So summarize.
Yes, ma'am. 32-year-old male patient who presented with repeated episodes of hematemesis since the last 15 years, which were well controlled with therapeutic endoscopy and followed by transient ascites and pedal edema. And having a dragging type of abdominal pain since since year 2018, was apparently was investigated with blood test, urine test, CT, and liver biopsy in the year 2017. Now apparently asymptomatic for last 4 years and presenting with a recent episode of unprovoked hematemesis followed by ascites and pedal edema since the last 1.5 years. 1.5 months, sorry. So case of likely is a case of next slide is likely is a case of total hypertension in the form of ascites and GI bleed without evidence of jaundice, hepatic encephalopathy, renal dysfunction, coagulopathy, or peritonitis. Etiology, first diagnosis, I would like
No,
to
what is it? No, this is not the way to say, no? So what is your syndromic diagnosis? Srividya, what is the syndromic diagnosis? What will be a syndromic diagnosis?
Portal hypertension.
Yeah, recurrent variceal bleed, no? It is a recurrent bleed. Recurrent variceal bleed will be your primary diagnosis, no? Recurrent variceal bleed with a splenomegaly. That's what is happening. And the patient is likely to have portal hypertension and complicated by complicated recurrent GI bleed and more recent decompensation. No? Decompensation is there. Ascites and edema leg is now persistent. I think that's what she said. Is the patient having ascites?
persistent? Yes, ma'am.
Persistent for how long?
So, ma'am, now it's been since around say last week of July, so around a month and a half.
So it is present. So therefore now it is it is portal hypertension. Most probably you want to discuss whether it's EHPVO or it is non-cirrhotic intrahepatic portal hypertension or it is cirrhosis CTPA, which is now decompensated. That will be the last for discussion. Complicated by recurrent GI bleed and ascites. Now it's decompensated.
Yes, ma'am.
Now it is for 6 weeks or 4 weeks, his patient has got ascites.
Yes, ma'am.
And in absence of HE, you have to mention that. Absence of HE, but there's no oliguria, no renal dysfunction. If there's no oliguria, you have to mention the important salient negative points with the performance scale of whatever it is. So what do you think between EHPVO, NCPF, and cirrhosis CTPA? Which of these three things you think the patient is likely to have?
NCPF seems more likely.
No, you have to discuss. You have to discuss all the three.
Ma'am, the age of presentation is around he's 15 years old in the second decade almost, slightly younger, but the more commonly NCPF is present at this age. Then he's giving a history of
NCIPH present much later. Okay, presents around 20 to 40 years, much later.
Then there is history of that dragging pain in the left upper abdomen, which is more likely because of an enlarged spleen, which would be more commonly seen in NCPF. There is no history of jaundice or any failure to thrive or failure to catch up in childhood or malnutrition.
Why do you want to say that? Failure to thrive and malnutrition?
Ma'am, EHPVO, those would be more likely as opposed to NCPF.
It's not like that. It's not failure to thrive. The growth is stunted, that's all. Otherwise they're normal. So the differentials will be in a patient, EHPVO seldom goes in for liver cell.
Yes, ma'am.
NCIPH is more likely because they can present at this little later age in childhood and almost touching adolescent, presenting with massive splenomegaly, recurrent bleed, and ascites is now present, indicating that the patient is like progressing from NCIPH towards cirrhosis. And these papers you should read. The natural history of NCIPH2. We have written our own review article in one JAPI, I think it's appeared. And EPEN has also come out with some publications where we all believe that the pathology is in the second or third degree branches of the intrahepatic portal radicals, causing perisinusoidal fibrosis and progressing towards cirrhosis. If you take over 8 to 12 years, we found that 20% of patients with so-called NCIPH has gone to cirrhosis. However, EHPVO seldom will never go for a cirrhosis because it is a slow flow system into the sinusoids. Okay, so that's what it is. What is the role of liver biopsy, you think, Sujit, this particular patient? We'll wind up another 5 minutes.
Ma'am, in this patient would be to rule out other causes of chronic liver disease.
So suppose in the ultrasound, we do not know what it is. The ultrasound had shown cavernoma and liver is normal. There's no role for liver biopsy, okay? EHPVO. In NCIPH, if you really want to do a liver biopsy, you have to take a core biopsy at the porta. Either you do a transmural biopsy to reach the porta or you do a core biopsy during surgery. There's no role for wedge biopsy. There's no role for liver biopsy in NCIPH. So NCIPH will not come as a liver biopsy is not indicated in this patient based on whatever presentation she's made. Okay?
Yes, ma'am.
So what was the finding on examination? Let us wind up.
Ma'am, he had severe pallor. There was a pedal edema and ascites. And in the systemic examination, there was the spleen was a moderate splenomegaly.
So the percentile, other thing in the exam, if you can get a percentile chart in the ward, ask for the percentile growth chart and learn how to draw it. Sometimes you will get these EHPVOs. So learn how to draw the percentile growth chart. You must know how to draw the chart, and therefore, if there is available in the ward, try to get the chart and learn how to draw the chart. Okay, then anything else positive? Abdomen.
Ma'am, ascites ever shifting dullness was present and splenomegaly was present. Liver was not present.
How big was the spleen?
Ma'am, 5 centimeters from the left.
5 centimeters spleen, kahan se yaar? Dragging pain. How will you get a dragging pain with a 5 centimeter spleen? Be very careful. Be very careful in your presentation. Don't take it in a lighter manner. 5 centimeter spleen is a difficult spleen to palpate, even on palpation in a patient with ascites. Okay, so don't bring it back. So now it looks more like not like an NCI patient, it's more like an EHPVO and ascites, decomposition, maybe he's got a chronic HPV infection or some other infection with the cirrhosis overlap. All these have to be considered as a differential. Now, quickly, can you just tell what was the findings on investigation? What investigations will you ask, Sujit?
Ma'am, actually...
1 minute, just two or three investigations.
Blood investigations, I would ask for a complete blood count.
Yeah, so we need to know hypersplenism. No, we need to know there's hypersplenism. That's important. And a good peripheral smear. And level 2 investigation will be?
Liver function test.
Ultrasound and Doppler. That's all.
Ultrasound and Doppler.
Because that will give you a takeover as to how you should investigate further.
Yes, ma'am.
So level 1 investigation would be just to get a basic blood test done to ensure that there's no any other problem, any hypercoagulable states, and then proceed for an ultrasound with Doppler. So what was it? What was the finding? What was the finding on?
The platelet count is low, 43,000.
43,000. Okay. INR is near normal, 1.33. Okay, then. Okay, what was the ultrasound and Doppler?
Ma'am, it was not done, ma'am.
Okay, then tell us the CT finding. This is where you land up with problem, no? 17 centimeters spleen on CT, and then you're saying a 5 centimeter on clinical examination. That means your examination is totally wrong. You cannot miss a 17 centimeter spleen. Be very careful in the exam. So the patient has got a massive spleen, and there's occlusion of the portal veins and the confluence, and there's moderate ascites, bilateral pleural effusion. So there is an underlying cirrhosis going on in this patient. Okay, there is portal venous thrombosis. There is some underlying liver disease also going on in this patient. HBV, HCV are all negative?
Yes, ma'am.
So what is your diagnosis at this stage? Sujit?
Extrahepatic portal vein obstruction causing portal hypertension and recurrent variceal bleed with features of chronic parenchymal liver disease and decompensation in the form of ascites.
There is absolutely, yes. There is. So you have to do active fluid. What was the active fluid analysis?
Ma'am, it was not done, ma'am. Actually, he had just come for the procedure, ma'am. So,
Okay,
not evaluated
just tell
further.
us the endoscopic finding.
There were large varices, large esophageal varices, out of which active oozing was seen
So
in
in
one.
this particular patient, just one last one or two questions. What will be the role of HVPG? So just remember this one dictum, no? If the varices are not getting obliterated in your second or third session, just revise your diagnosis. What are you dealing with? What is the HVPG? What do you expect the HVPG to be in this patient?
Normal or slightly raised.
Yeah, so it will be between
7 to 10. 7 to
8 to 10. It will be between 8 to 10. So there's something called subclinical now and then clinically significant. So it will be between 8 to 10. That's what we expect. So HVPG is very important in this patient. In a patient who's having recurrent bleed with this type of a problem, how would you manage this patient now?
Ma'am,
So how would you manage this patient?
endotherapy has already been done. We would put him on non-selective beta blockers to prevent further bleeding.
Then all the vessels are blocked. SME is blocked. All the vessels are blocked, and I think they're all old thrombus. So you have to do a prothrombotic workup. You have to complete a prothrombotic workup for the sake of the patient that they needs on long term, so that other vessels, hepatic venous outflow system, and all don't get blocked. So that is important. And then when all these vessels are blocked, how would you manage this patient? So is there a role for tips in this patient? So you can do tips. Yeah, you can do tips in such patients because they are able to canalize through the thrombus. They're able to get into the vein. So tips is still a procedure of choice in such patients. And there are some papers, I think from Italy or someplace, where they've gone through the transsplenic route, they've gone into the splenic vein, into the cavernoma, and then drained into the disc and reached the disc, and they've done a rendezvous procedure for a TIPS. So these are the advances that are taking place. So in this particular case, I don't think it's a case for transplant. So patient will be on non-selective beta blockers, but we have to do some other procedures so that we're able to relieve him of his GIP. And if the liver volume is good and otherwise the INR is normal, there's no hyperammonemia, other things are all okay, then this is a candidate where you can do a TIPS for managing the recurrent variceal bleed. Any suggestion? What happened to the patient?
Lost to follow-up.
Lost to follow-up. So anyway, we'll come back again. So that is one. Other thing is please read the classification. No, this will be type 4, I think. This will be 4. So get the the duration, the extent. You have that classification. No, Abby's and Dr. Sarik's paper, the portal vein thrombosis. So go through that. All right.
Yes, ma'am. Type 4.
Yeah. So
one question, ma'am. So now in this patient, can the term PS, portosinusoidal vascular disease, be used because he has features of this portal vein thrombus also?
That's the same thing, no? That's what we said. NCIPH, no? It is behaving like an NCIPH, is progressing to cirrhosis. You can use a new terminology, portosinusoidal vascular disorder. But in the recent NASL, they clubbed too many things in that disorder. They even included FLH. They even included regenerative nodular hyperplasia. So people are still confused as to what are the constituents of portosinusoidal vascular disorder. So read what is there in Bedino, just read the classification, mention that in the exam. But in us, we had a lot of confusion as to what should be included in portosinusoidal vascular disorder. Okay, so in this particular case, have a nice table differentiating pH, PVO, and NCIPH. Very important, 20 to 40 years, right from the age of presentation, etiology, normally that's how you discuss HVPG, management, role of liver biopsy, and finally role of shunt procedures, management. Read the earlier papers, shunt procedures, especially for examiners from North and all, they used to do a lot of shunt procedures. So just read a little bit more about that. Here, of course, the thrombosis is extending all over. So today, TIPS is one of the choice procedures. and people are going to the transpenic route, read that. Just open up and read management of portal vein thrombosis, recurrent GI bleed, transpenic approach. We'll get that reference. All right.
And ma'am, we would also want to anticoagulate him because of this extensive thrombus. Now that we have controlled
If
the
there are a
bleeding.
lot of collaterals, it's of no use. Long-standing thrombus, there's no role. Okay, there's no role. But you have to do the prothrombotic workup so that thrombosis does not occur in the hepatic venous outflow system and other systems. So for that, you have to do the workup. All right? We conclude now. Okay, thank you. Thank you. Okay. Join us on Tuesday. Yeah.
Thank you, ma'am.
Thank you.
Thank you, Arish.
Thank you. Good night, ma'am.